Hello and welcome. This is my 5th class on instruments. Today I'll be talking on needles, and this is also important for exams. This is asked during Viva exams. Starting with bone marrow aspiration needle. It looks like this, and let's start with the parts. So this is also known as sternal puncture needle, and this is short and stout. The different parts will be needle. Number 1 needle, that is, this is the needle which is hollow with a bevel sharp tip. And then number 2, it has a stylet or trocar. So this one is the stylet or trocar. This is a solid inner rod which is giving support to the needle. Number 3, it has a guard. This one is guard. This one, a guard is attached here. So guard with a screw. This controls the depth of penetration, preventing over entry of the needle. Then there is a hub like this. So this is the proximal part where the nozzle of the syringe fits in while aspirating the bone marrow. Commonly used needles are Sala needle, and this is most commonly used in children. Other needles are Kima needle, Illinios needle. So there are many other more also, but these are commonly used. And Sala one is commonly used, so I'll be talking about this needle. There are different size and different site to do the bone marrow aspiration depending upon the age group. So in the infant age group, that is less than 2 years, the needle length should be 1 to 1.5 inch with a gauge of 18 to 20. And then site will be upper tibia at the anterior medial side. 2 to 10 year old, the needle length 2 inch, gauge is 16 to 18 gauge needle are used, and then the site used is posterior superior iliac spine. And more than 10 years, 2 to 3 inch length is required, 16 gauge is used, and then posterior superior iliac spine or sternum is used for doing the bone marrow aspiration. Let's see the sites in detail. So less than 2 year age group, just see in the picture, it is done in the anterior medial side of the tibia 2 cm below and medial to the tibial tuberosity. This is the tibial tuberosity, so 2 cm below and to the medial side of this tibial tuberosity. This is the site. And in case of 2 to 10 years, that is posterior superior iliac spine. Just follow the picture. Posterior superior iliac spine. So the landmark, this is present at back of the pelvis on either side of the sacrum. So either side of the sacrum, 2 places it is present. This corresponds to sacral 2 vertebra at the dimple of Venus. That is a small indentation that is seen in the lower back of every individual. So that is the site for doing bone marrow in age group 2 to 10 years. And then more than 10 years, the site is posterior superior iliac spine, and plus you can even do in the manubrium sterni. But this site is very rarely used because there is high chance of complications. So this is a posterior superior iliac spine where the bone marrow is being done. So you are penetrating the skin and subcutaneous tissue this way, and this is the periosteum, and then you enter the marrow. Okay, let's see the procedure in detail. First, you should take informed consent from the parents or guardians. Then take aseptic precautions, and then position is important. So position the child either in prone position like this or in the lateral decubitus this way. Step 2, you need to clean with the antiseptic povidone iodine plus spirit the area you're going to do the bone marrow. So you clean from central to periphery, then you drape with a sterile towel. Then use local anesthesia by using hypodermic needle. You inject 2% lignocaine straight till bony resistance is felt. So that will be the periosteum. Then see the length till which the needle has gone. Then in that you need to add 5 mm and then fix the guard of the bone marrow aspiration needle, because you are going to insert the bone marrow aspiration needle after that. So to just reach at the point, if you add 5 mm in that length of the hypodermic needle, then you will be reaching the correct place. Step 3. Insert the needle with the stylet in place perpendicular to the bony surface this way, and then by corkscrew method, just see the picture how this person is holding the needle. So you should hold the needle this way, and in a corkscrew method you need to rotate the needle and proceed forward till you feel the resistance. Then push a bit more till resistance give away. That indicates you are penetrating the cortex, and then you are at the site. After that you remove the stylet, and then in the nozzle you attach 20 ml syringe this way. Just follow the picture. Then aspirate 0.2 to 0.5 ml marrow, and then the indication that you have reached the marrow is the child will cry due to suction pain when you are pulling out the bone marrow. Then once aspirate is obtained, then apply pressure and remove the needle. Then make smear immediately of this aspiration material. Then apply pressure dressing at the site where you have done the bone marrow. Now let's see what you are going to see in the bone marrow film. So number 1, you need to see for the smear morphology. So that is the cellularity of the RBC, WBC and platelet. So number and activity of the erythrocytes, number and types of WBCs, and number and types of megacardiocytes. Those are the platelets. After that you see the myeloid erythroid ratio. Then you see for the abnormal cells, which can be malignant cells, parasites like malaria parasite or many times Kala-Azar, organisms like typhoid, salmonella. So then after that iron content of the marrow can be also detected by seeing the iron stain, which is a gold standard for diagnosing the iron deficiency anemia. Now come to indication, which is very important and very frequently asked in exams. So let's start with the hematological disorders where bone marrow aspiration is mandatory. So if you suspect leukemia, lymphoma, in cases of pancytopenia, to diagnose aplastic anemia, iron deficiency or megaloblastic anemia can also be diagnosed, and idiopathic thrombocytopenia, where you think it is due to secondary causes, and then myeloproliferative disorders. And some infectious disease are there where bone marrow is done when the serology is not helping. So number 1, Kala-Azar can be diagnosed to see the organism. The amastigote forms are seen, and then enteric fever to isolate the salmonella, and then pyrexia of unknown origin as a second line investigation, it is done, and then microfilaria, malaria can also be detected. It is also done in the storage disorders like the inborn error of metabolisms like Gaucher's disease, Niemann-Pick disease. So in these conditions, different storage demycopolysaccharidosis, so all these storage diseases, bone marrow is indicated, and also in the hypersplenism. And therapeutic use of this bone marrow aspiration needle is intraosseous fluid administration. When peripheral lines are not obtained, not available or not seen during emergencies, then you might have to do the intraosseous fluid administration. So this way site will be same, 2 cm below and medial to the tibial tuberosity. Then let's see the complications that can occur. So number 1, local bleeding or hematoma can occur. Number 2, suction pain, then infection, shock, osteomyelitis, mediastinitis. This is a very bad complication when you are doing the sternal puncture, where there is 100% fatality. So you have to be very careful while doing the sternal puncture. Contraindications: it is contraindicated in osteomyelitis if there is a severe thrombocytopenia an infection at the site of doing bone marrow. Next is bone marrow biopsy needle. So it is longer and thicker than the bone marrow aspiration needle. Then it helps taking out increased marrow material, and it is not done in the sternum but it is done in the posterior superior iliac spine. So indication will be same as the bone marrow aspiration, but this is specially done when there is a dry tap, as in aplastic anemia or myelofibrosis. When you are doing a bone marrow aspiration, there is a dry tap, nothing is coming out. So in that scenario you have to do the bone marrow biopsy. Procedure is same, insertion same as bone marrow aspiration, and you proceed till sudden fall of resistance. So after this, in case of aspiration, you put a syringe in the nozzle and then aspirate the marrow content, but here you are supposed to withdraw the stylet a bit and advanced only the needle slightly further in different direction. Just push the needle in different direction to break specimen at distal cutting edges of needle. After that, take out the needle by rotation, and then specimen is removed from needle by probe. So in the needle the bone marrow material is stuck, so with the probe you take out the material. So what is seen in the bone marrow biopsy? Here you see the cellularity, that is RBC, WBC, platelet, same as bone marrow aspiration. Then after that you need to check for fibrosis, infiltration, and also diagnosis and staging of lymphoma is done by bone marrow biopsy. Next needle is lumbar puncture needle. Here also needle also has two parts. One is stylet, another is lumbar puncture needle. See, this needle is also hollow like a bone marrow aspiration needle. The parts stylet or trocar, we had seen that solid inner wire which fits tightly inside the hollow needle and makes the needle solid and provides strength to the needle when you are doing the procedure. Number 2, sharp hollow needle is there with the short bevel tip, and there is a hub like this, needle hub, stylet hub in the upper part of the needle, so that can be connected to the syringe. After you take out the stylet hub, then in this needle hub you are going to connect the syringe, or from this CSF fluid also comes out. Different types of needle. One is disposable malleable plastic material, so this one is more commonly used, and another one is available that is made of metal, which is more stiff, and this can be reused after sterilization, and this used to be used earlier, but these days you use the disposable one. So different size here also, like bone marrow needle, different size of the needle is available depending upon the age. You should be using different size needles. So in case of neonate or infants 22 to 25 gauge, you use a hypodermic needle instead of the lumbar puncture needle. Hypodermic needle can be used till infancy. So 22 to 25 gauge, length is 38 millimeter and then 1.5 inch. In case of children beyond infancy, 22 gauge needle, lumbar puncture needle, or that is 63 millimeter length, 2.5 inch is required. And in case of adults, 20 to 22 gauge needle with a length 90 millimeter or 3.5 inch is used. Now come to the procedure how you are going to do. First, take the informed consent from the parents, guardians. Then you sedate if the child is younger or if the child is uncooperative, using midazolam or phenargan, so whatever is you are using in your center. Then you need to position the child. There are two positions that can be used. One is lateral decubitus, and this is more commonly used. So here the child is lying like this, laterally in the lateral decubitus with the knee chest position. That means flexing the neck, flexing the knee, and that is going to increase the intervertebral space. So in a bigger children, you can do even in the sitting position. Here also child sits and leans forward, hugging a pillow. So when the child does this, the intervertebral space is increased, so it is easy to push the needle. Then site used is, you use Toothpierce line. So this line, this is a line between highest point of iliac crest on either side. So just take the highest point of iliac crest on either side and draw imaginary line. So that is Toothpierce line, which intersects the L4 lumbar 4 spinous process. Then you clean this area with the antiseptic using povidone iodine spirit and drape it with a sterile towel. Then infiltrate local anesthetic, lignocaine in skin and deeper tissues. And sometimes you can even use the local spray, anesthetic sprays. And then insert the needle with the stylet at level L4, L5 intervertebral space. If not found in the L4, L5 space, then you can go one space up, that is L3, L4. But in case of adults, you can go up to L2, L3. Then needle should be ideally pointing towards acromion process of shoulder. Advance the needle till there is fall of resistance. That means that indicates you have reached the space, that is the subarachnoid space where the CSF is available. Then stylet is removed and free flow CSF drips out from this end, from this needle hub. Then you need to collect the CSF in 4 sterile bottles or sterile containers. Number 1 bottle goes to the biochemistry lab for glucose and protein detection. Number 2 to the microbiology lab where you do culture, gram stain and PCR. Number 3 tube or the container goes to the pathology lab where you are going to do the cytology of the CSF. Then number 4, that is usually in the developing countries, goes to WHO lab for Japanese encephalitis surveillance. So if you are doing for other purposes also, you can use this 4th tube. So see the lumbar puncture, this way you do, and CSF flows through this. After you take up the stylet, CSF flows freely from this hub. You collect in the containers. Then post procedure, you reinsert stylet before removing needle to reduce the post lumbar puncture headache. Then apply small sterile dressing there. Keep child supine position for 30 to 60 minutes. Then you need to monitor headache, vomiting, back pain, signs of neurological changes which might occur after the lumbar puncture. Okay, just see the structures which you are piercing while you are doing the CSF analysis. This is frequently asked in exams, so I am just showing you the structures which are pierced. Is number 1 is pierce the skin, then subcutaneous tissue, then supraspinous ligament, then interspinous ligament, then ligamentum flavum, then you reach the extradural fat, then you reach the dura mater, then you reach the subdural space, then arachnoid mater, then enter to the subarachnoid space where the CSF is available. So this yellow is the spinal cord, and then this blue one is the arachnoid space where the CSF is flowing. So this needle has entered the cerebrospinal fluid space. So this is the subarachnoid space. Indication of doing lumbar puncture. So there are diagnostic and there is therapeutic uses of this. So diagnostic usually whenever you are suspecting meningitis or encephalitis, you do in the Guillain-Barré syndrome where you get the albuminocytological dissociation. This means protein level is very, very high, and whereas the cell level is very normal or very less raised, or it is usually normal. Then in subarachnoid hemorrhage you should do, and then pyrexia of unknown origin. Sometimes this is required to rule out meningitis, and then febrile convulsion in children less than 6 months. therapeutic use, intrathecal medicine when you are giving. So this is usually given in the leukemia cases when you are giving chemotherapy. And in the picture just see, this is a metallic lumbar puncture needle which was used earlier. And then intrathecal immunoglobulin, many times in case of tetanus they used to give, even intrathecal immunoglobulin can be given through this needle. Pseudotumor cerebri to release the intracranial pressure temporarily. And contraindication of this is raised ICP if there is a papilledema, and then local pathology is there like infections, meningomyelocele, or if there is a spinal deformity, it is contraindicated. If there are bleeding disorders, and then severe shock, or if the patient is hemodynamically unstable, then also you hold the CSF analysis. Okay, thank you. So I think I'll do one more instrument class, and then the instrument will be over. Then after that I'll start discussing on the emergency drugs, which is also important for the MBBS final exams. Thank you.